Hello, let's start the critical care station for MRCS Part B. We will start from the diabetes and then we will cover next stations. Okay, so let's start from the diabetes. So the scenario is 65-year-old patient with type 2 diabetes on oral medications presented with perianal abscess and went for incision and drainage. So the question one is, what are the types of diabetes and describe the pathogenesis of each. So diabetes is classified into two broad classes. Okay, one is type 1 diabetes and the second one is type 2 diabetes. Type 1 diabetes is characterized by absolute deficiency of insulin secretion. Okay, so there is deficiency or absence of insulin secretion caused by pancreatic beta cell destruction. Okay, so pancreatic beta cells destruction occurs in type 1 diabetes, which causes the deficiency of insulin secretion. Okay, usually resulting from a autoimmune attack. Type 1 diabetes accounts for approximately 10% of all cases. Then the second type is type 2 diabetes. Okay, this is type 2 diabetes. It is caused by combination of peripheral resistance. Okay, so the first mechanism is peripheral resistance to insulin action. Okay, so basically there is resistance to insulin action and inadequate compensatory response of insulin secretion by the pancreatic beta cells. Okay, so basically there is relative insulin deficiency. Okay, so the beta cells are secreting insulin, but there is peripheral resistance to insulin action. Okay, and approximately 80 to 90% of patients have type 2 diabetes. Okay, the second question is, what is the function of insulin and what are other hormones affecting blood glucose level. Okay, so functions of insulin, uh, the principal metabolic function of insulin is to increase the rate of glucose transport into certain cells in the body. So what it does for the carbohydrates, so it increases the uptake of glucose into various tissues. The second function is stimulate glycogenesis in many tissues, but especially in the liver. Okay, and it inhibit the gluconeogenesis but stimulate the glycogenesis. Okay, then it stimulates the hepatic generation of glucose 6 phosphate from glucose. So these are the functions for carbohydrates. Then what is the functions on protein, or what are the effects of insulin on the protein? So the first function is it enhances the uptake of the amino acids into peripheral tissues. The second action on protein is that it stimulates the protein synthesis. For this reason, insulin can be regarded as one of the growth hormones. Then effects on fats. So first effect is that it stimulates the lipid uptake into cells, and the second function is it enhances the oxidation of lipids once inside the cells, and the third function is it also causes the fat deposition by stimulating lipogenesis, the formation of lipid in adipocytes and the liver. Okay, so insulin has function on adipose tissue, on striated muscle and liver. In the adipose tissues, it increases the glucose uptake, it stimulates the lipogenesis but inhibit the lipolysis. Then the action of insulin on striated muscle, that it increases the glucose uptake, increases glycogenesis or glycogen synthesis, and increasing protein synthesis, while in the liver it inhibit the gluconeogenesis, stimulate the glycogen synthesis and stimulate lipogenesis. So these are the actions of insulin. Other hormones which affect the blood sugar level. Okay, so glucagon, it increases the blood glucose level. Catecholamines like epinephrine and norepinephrine also increases blood glucose level. Glucocorticoids, most important being cortisol, it also increases blood glucose level. And somatotropin, a pituitary hormone, also increases the blood glucose level. Now the question 4 is precautions for diabetic patient going for surgery, how to prevent intraoperative hypoglycemia. So first precautions for diabetic patient going for surgery is this one. Okay, first we will do investigation like ABGs and potassium level, and then if the patient is on oral medication and the glucose is controlled, just omit the morning dose. But if the blood glucose is not controlled by oral meds, then convert him to variable insulin infusion therapy. Okay, so that's the first precaution. Then patient with patient with diabetes patient with diabetes must be prioritized in the operating list. Okay, then the second precaution, routine overnight admission is not necessary. Starvation time should be not more than one missed meal. Analgesia and antiemetics should be used to enable early return to diet and usual insulin regime. Insulin infusions should only be used if a patient is expected to miss more than one meal. Then post-operatively we have to use the 0.45 sodium chloride with 5% dextrose, okay, glucose, and 0.15 or 0.3% KCl is the recommended IV fluid. Okay, so this is the recommended fluid. Then the capillary blood glucose should be measured hourly during and after any surgical procedures. Okay, capillary blood sugar hourly. And the WHO surgical safety checklist should identify all diabetic patients. Okay, the target blood glucose should be the target blood glucose should be 6 to 10 millimole 6 to 10 6 to 10 millimole per liter. Acceptable range is 4 to 12 millimole per liter. Okay, so that are the precautions for the diabetic patient going for the surgery. Now what type of insulin you going to have in variable insulin infusion? Okay, previously called sliding scale. So we will have to use the short acting insulin, okay, in variable insulin infusion. Then immediate and late post-operative complications of diabetes. The immediate complication can be hyper or hypoglycemia, dehydration with electrolytes imbalances, hyperglycemic hyperosmolar syndrome, and diabetic ketoacidosis. And the late complications can be infection, sepsis, and impaired wound healing. Post-operatively, who you will involve in care of patients? So endocrinologist, his GP, and his family. Then what do you think this patient might need if the diabetes is not controlled on oral medication? So we already discussed it in precaution that if the diabetes is not controlled on oral medication, then we will use the variable insulin infusion, and that insulin will be short acting insulin. Okay, short acting insulin. Okay, so these are the question we already covered. Okay, So mention the investigation. This question mention investigations you would request to confirm the diagnosis of diabetes mellitus. So we will have to um, arrange or take the blood for the oral glucose tolerant test, fasting blood glucose, and HbA1c. So these are the tests or investigation to confirm the diagnosis of the diabetes. Okay. Now the next station in the critical care is hypotension in pregnant lady. The scenario is this one: 34 weeks pregnant, is undergoing open cholecystectomy for necrotizing cholecystitis. BP is decreasing, heart rate is decreasing, reverse Trendelenburg position, placed in reverse Trendelenburg position, combined GA and epidural. The operation is taking longer duration than expected. So the question is benefits and risk of this patient undergoing this operation. So the question is basically, is the surgery is necessary in this patient, because the she is 34 weeks pregnant and has undergone the open cholecystectomy for necrotizing cholecystitis. So the benefits in the for the patient to do surgery is that there will be control of infection. Okay, the source of infection will be control, which may be leading to the sepsis and induction of the preterm labor, while the risk of the surgery is that preterm labor, intrauterine fetal demise, and DVT, deep venous thrombosis, for long duration. So who to involve in care? So we will involve neonatologist in case of preterm labor, okay, obstetrician, microbiologist, ITU registrar, anesthesiologist, and surgeon. Then we are to manage this case post-operatively, post-obstetric HDU. So we are to manage, so we will manage this patient in obstetric high dependency unit. Okay. Then why blood pressure is decreasing? So it has many reasons. Okay. Compression of inferior vena cava by the uterus, which will decrease the venous return, okay, which will decrease the preload, thus decreasing the cardiac output. So this is Frank-Starling mechanism. Decreasing the venous return will decrease the preload, and decreasing preload causing the decrease in cardiac output. Then the second reason of blood pressure is decreasing at that the reverse Trendelenburg position, causing the pooling of blood in left lateral position. Okay. Then the sepsis is the other reason, which is from necrotizing cholecystitis. Okay. And then the fourth reason is that there is effect of anesthesia, epidural anesthesia. Okay. So these are the reason why there is decrease in blood pressure. Okay. Then the simple measure to increase the BP, repositioning to lateral. Okay. The second measure is to pull the gravid uterus to the left side away from the inferior vena cava. Then raise patient's leg, which will cause the increase in venous return. So these are the simple measures. Okay. Then what is preload? Question 6 is, what is preload? It is the end diastolic volume that stretches the right or left ventricle of the heart to its greatest dimensions, or the amount of myocardium that has been stretched at the end of diastole. Okay. So the blood which is coming to the heart, right ventricle or left ventricle, which causes the heart to stretch, this is preload. Okay. Then what is shock? Shock is circulatory failure resulting in adequate organ perfusion, for example, cannot meet the metabolic demands. Okay. So the next question is, what will be the body response to decreasing blood pressure? So the body response can be of two types. There will be some neurogenic reflexes and there can be hormonal response. So in the if the body response to decreased blood pressure is that baroreceptors stimulate sympathetic activity, producing a compensatory tachycardia, increased stroke volume and peripheral vessel constriction. Okay, systemic vascular resistance will be increased. This will increase the cardiac output and maintains the blood pressure. Okay, so first is the baroreceptor response, and then the other response is hormonal response. So the hormones which are secreted or released in the a patient when he or she has decreased blood pressures are catecholamines, mineralocorticoids. Okay, so the catecholamines, the adrenal medulla. Okay, it is secreted from the adrenal medulla. The adrenal medulla is stimulated by pain and injury and releases hormones to cause the peripheral vessel constriction, for example noradrenaline, which causes the increase in systemic vascular resistance. Then the second hormone is mineralocorticoids. The adrenal cortex, it is released from the adrenal cortex. It releases the hormones to stimulate salt and water retention, for example cortisol, to increase the blood pressure. As in the decreasing blood pressure patient, there is reduction in the circulatory volume and increased sympathetic activity, which stimulate the renin release from the macula densa of the juxtaglomerular apparatus of the kidney to stimulate the renin angiotensin aldosterone cascade. A resultant increase, so the renin release causes the formation of angiotensin 1, angiotensin become the angiotensin 2, and then angiotensin 2 stimulate the release of aldosterone. So the aldosterone causes the increase in salt and water retention, helps to restore circulatory volume over several hours. Okay, so these are the body response to decreased blood pressure. Now, what is the physiological response to standing up? Standing up lead to pooling of blood in the peripheries and hence decrease venous return to the heart. By Starling's law, this result in temporary reduction in cardiac output because BP is equal to systemic vascular resistance into cardiac output. This leads to reduction in BP. This fall in BP is sensed by the baroreceptors in the aortic arch and carotid sinus, leading to reflex constriction of the arterioles and capillaries. This increase in systemic vascular resistance results in the normalization of the blood pressure. Okay, sympathetic stimulation caused by the fall in cardiac output also result in reflex tachycardia. In addition, the increase in sympathetic drives causes an increase in contractility. Okay, so the summary of this question is that when we stand up, it leads to pooling of blood in peripheries, which decrease the venous return, and by compensatory mechanism the baroreceptors stimulate and it causes the constriction of the arterioles and capillaries, which increase the smooth systemic vascular resistance, which normalize the blood pressure. Also, the baroreceptors stimulate the sympathetic activity, okay, which causes the reflex tachycardia and increase in contractility. So this is how the physiological response to standing up. What is baroreceptors? Baroreceptors are basically the mechanoreceptors located in the carotid sinus and aortic arch. Their function is to sense blood pressure changes by responding to change in the tension of the arterial wall, supplied by the sinus nerve of Herring. okay, which is the branch of cranial nerve 9 glossopharyngeal nerve. Okay, so this is about this. Now the next question is factor affecting the venous return. So there are many factors, okay, the muscle contraction and decreased venous compliance, these two factors, and also the third one, sorry, these three factors. The first factor, like muscle contraction will promotes the venous return. Decrease venous compliance, like when there is sympathetic activation, then it will decrease the venous compliance, which promotes the venous return. Then the respiratory activity during the inspiration, okay, the venous return increases because of decrease in right atrial pressure. So these three factors increases the venous return, while these two, vena cava compression and gravity, will decreases the venous return. Okay, so vena cava compression basically occurs like in the Valsalva maneuver or during late pregnancy, which decreases the venous return, and gravity also decreases the venous return. Then the next question, can you name some devices used in mechanical DVT prophylaxis, may be used to improve circulatory parameters in this patient? So we can use the intermittent pneumatic compression devices, TED stocking, thromboembolic embolic deterrent stockings. Okay, so TED stocking and intermittent pneumatic compression devices, it can be used for DVT prophylaxis. Now the next question will be is what can be done to improve the preload of this patient. So for improving preload, we can give the fluids, inotropic agent and vasopressor agents. So what are the actions of inotropes? So there are adrenergic agonist, okay, inotropes can be adrenergic or dopaminergic. Okay, so adrenergic agonists like adrenaline, noradrenaline, isoprenaline, it these agents increases the systemic vascular resistance through vasoconstriction, heart rate, stroke volume and resultant cardiac output to increase the systolic blood pressure. Okay, then the dopaminergic agents, it has some adrenergic activity like dopamine, dobutamine, dopaxamine, increases the heart rate, stroke volume and resultant cardiac output and contractility to increase the blood pressure, but depending on dose. Okay, so dopamine has also can also cause the contractility, but it can also cause reduction in the sympathetic vascular resistance to produce vasodilation, but it depends on its dose. Okay, it's depend on its dose. Then next, so this is the next station, pain management. Okay, the scenario is patient with severe post-operative pain, drug chart, received only Panadol and Ercosia, which is selective COX-2 inhibitors. You have been asked to see a 50-year-old man 9 hours following laparotomy. His weight is 90 kg, time now 22:30. He complains of abdominal pain. He is conscious, alert. Review charts shows the pain relief is not adequate. Okay, the surgical site is normal, and the patient is hypertensive and tachycardia. So define pain. Okay, the first question is define pain. So it is unpleasant sensory or emotional experience associated with actual, okay, associated with actual or potential tissue damage. What to do after seeing this drug chart? Okay, so the patient is receiving only Panadol and selective COX-2 inhibitors. So what you will do after seeing this drug chart? So first, investigate why PRN medications were not given and file an incident report. Next question is, how will you manage this patient after this drug chart? Okay, so the management can be immediate management and full patient assessment. So in the immediate patient, just like the other patient which are critically ill patient, this patient is critically ill patient, and the patient is in pain. So patient assessment is vital. It should follow the same criteria for critical surgical ill patient. Okay, so it will follow care of the critically ill surgical patient, assessment as in other circumstances. So first we will have to look at the airway. Okay, airway, start at the beginning by checking that the patient has a patent airway or not. Then breathing, check the respiratory rate, pattern and depth of breathing. So is your patient's respiratory function impaired by inadequate analgesia? Can he or she cough or expectorate properly to avoid problems later? Okay, so you have to check the breathing, respiratory rate, pattern and depth of breathing, that is the respiratory function is impaired by inadequate analgesia or not. So the circulation, in the circulation, tachycardia, is the patient has tachycardia, so the tachycardia should not automatically be assumed to be caused by pain. There is commonly an underlying cause, but should not be assumed. A persistent tachycardia or hypertension caused by inadequate analgesia may potentiate the development of myocardial ischemia. Okay, so this is important, particularly in the patient who is already hypoxemic. Then disability, it is important to assess whether the method of analgesia is contributing to the patient's clinical deterioration. Particular attention should be paid to the patient's level of consciousness, as decreasing conscious level is an early indicator of opioid toxicity. Then the full assessment of the patient after the immediate actions or management, we have to fully assess the patient. Review the chart. If the pain is relief is felt to be contributing to the patient's deterioration, the drug chart should be reviewed with the following questions in mind. Is effective analgesia prescribed? Is effective analgesia being given? Is the treatment appropriate for this patient? Then we have to take history or look at the history and systemic examination. Then investigation that should be sent will be serial ABG analysis and check X-rays for atelectasis. Decide and plan. If the pain relief is adequate and the patient is improving, then continue and review. If the pain relief is inadequate, determine why. Is it due to failure of the method of analgesia? Is it due to incorrect implementation of the method chosen? Or is it due to the development of surgical complication? So we must report this acute pain to multidisciplinary team. Acute pain services, multidisciplinary acute pain team consists of surgeons, anesthesiologists and nursing staff and pharmacists. Okay, so then the side effects of opioids, adverse effects with the acute use and adverse effect with chronic use. So with the acute use, the adverse effects are respiratory depression, nausea and vomiting, pruritus due to release of histamine, secretion, constipation, urinary retention, delirium, sedation, myoclonus, seizures. Then the adverse effect with chronic use are hypogonadism, immunosuppression, increased feeding, increased growth hormone, withdrawal effects, tolerance and dependency, abuse and addiction, hyperalgesia, impairment while driving. Okay, so these are side effects of acute and chronic use. Now, pain intensity escalation and management. So if there is mild pain, then paracetamol or NSAIDs should be given. Okay, if the pain is mild to moderate, then combination analgesia, which will include the so the combination analgesia are a mixture of weak oral opioids and paracetamol. So in the mild to moderate pain, we will give the combination analgesia with or without NSAIDs. Then for the moderate pain, oral opioids, weak, it may be weak or strong opioids, or combination analgesia with or without NSAID. For moderate to severe pain, oral opioids, okay, weak or strong, plus paracetamol, okay, and with or without NSAIDs. Then for the severe pain, we have to use the parenteral opioids, IV, IM or subcutaneous, plus paracetamol, or with or without NSAIDs. But we can also use epidural anesthesia or epidural analgesia, which include local anesthetic with or without opioids. Okay, so this is for the severe pain intensity. What is the pain pathway? So pain is transmitted through fast A delta fibers, which is sharp pain for sharp pain, and slow C fibers for dull pain, to lateral spinothalamic tract, then to the thalamus. Okay, so what happens? So these are this one on the right side is pain pathway. So what will be the pain pathway? So the receptors for pain, like in the upper limb pain receptors and lower limb pain receptors, it will transmit the pain through sensory fibers. So these are the sensory fibers. Okay, it may be A delta fibers or slow C fibers. A delta fibers for sharp pain and C fibers for dull pain. So these sensory fibers transmit the pain from the pain receptors to the spinal cord. Okay, it terminates in the dorsal horn of the spinal cord, and then it gives the tract, which is called spinothalamic tract. Okay, so these are the spinothalamic tract. So each of the spinothalamic tract will take the pain impulse from the sensory fiber in the dorsal horn, then it decussate to the other side. Okay, so it comes to the other side or the opposite side, and it goes upward. Okay, it goes upward in the lateral anterior ventrolateral quadrant of the spinal cord through the spinothalamic tract. Okay, it ascends up to the thalamus and the which of the nucleus of the thalamus. So it goes to the ventral posterolateral or VPL nucleus. Okay, and then from the ventroposterolateral nucleus, it travels to the primary sensory cortex. Okay, so this is the primary sensory cortex. So this is the spinothalamic tract. It is the ascending tract because it ascends upward from the peripheries to the central nervous system. Okay, then what is the substance released from damaged cells? This question, what will be the substances released from damaged cells that will cause pain? So these are the substances: bradykinin, free radicals, histamine, substance A, and leukotrienes and serotonin. Then moving to the next question, question number 9. Question number 9 is, patient pain failed to settle. Anesthetic ST2 recommend patient control analgesia PCA. So what is PCA? Patient control in analgesia PCA is a syringe pump connected IV to allow the patient to self-administer boluses fixed dose of morphine. Overdosage is avoided by limiting both the size of the bolus and the frequency of administration. A lockout time is set within which pressing the button again will not result in the bolus of analgesia, and there is one-way valve which prevents the backflow of opiates into the infusion chamber, which may lead to overdose. Okay, so it may lead to overdose when redelivered. Okay, so these are the this is about the patient control analgesia or PCA. Normal dose of morphine in the PCA 0.2 to 2 mg bolus. Okay, 0.2 to 0.5 to 2 mg bolus. Now the question 11 is, what is the problem to use PCA? So the problem can be pump failure, IV set failure. Patient has to be alert and oriented to be able to use it. It can break down, run out of battery, sleep disturbance, not suitable for patients who are confused or who are unable to press the demand button for physical reasons, limits the patient mobility. Okay, so these are the problems with the using of the PCA, patient control analgesia. Then the question number 5, this is, what are the harmful effects of post-operative pain? Okay, so the complications or the harmful effects can be on the cardiovascular system, GIT and respiratory. On the cardiovascular system, it increases the heart rate and BP and myocardial consumption, which may lead to myocardial infarction. It can lead to DVT from immobility. Then the GIT causes, the GIT complication or the harmful effects are delayed the pain, delayed the gastric emptying, reduce the bowel motility and paralytic ileus. On the respiratory system, it has effects like it limits the chest movements leading to atelectasis, retained secretions and pneumonia. Okay, so these are the complications of the pain. Now how would you manage his pain initially? So after the ABCDE assessment, I will assess, or we have to assess the severity of the pain with one of the pain scales. Then we will consult the pain team if available. If no pain team available, then we have to give analgesia according to WHA analgesia ladder with the regular assessment. So the pain management can be non-pharmacological methods and pharmacological methods. So in the non-pharmacological methods, pre-operative explanation and education, relaxation therapy, hypnosis, cold or heat, splinting of wounds, transcutaneous electrical nerve stimulation called TENS. Pharmacological methods are simple analgesia like paracetamol, NSAIDs, opiates, and local anesthetic in the epidural or local infiltration. Give examples of opioids in common use. Which agents are synthetic and which ones are non-synthetic? Okay, so opioids can be weak or strong opioids, and in the non-synthetic opioids, there are morphine and codeine. 10% of this is metabolized to morphine. So in the codeine, um, in 10% of codeine is metabolized to morphine. Then the semi-synthetic is dimorphine, hydrocodeine. Then the synthetic are pethidine and fentanyl. Why is codeine bad? Okay, so the harmful effects of the codeine. It can cause the drowsiness, constipation, itching, nausea, vomiting, dry mouth, meiosis, orthostatic hypotension, urinary retention, euphoria, dysphoria, and coughing. Okay, then it can cause the rare anaphylaxis, okay, seizures, acute pancreatitis, and respiratory depression. Cytochrome P2D6, okay, cytochrome P40 enzyme converts the codeine into morphine in the liver. Some patients, which are called ultra rapid metabolizers, who have high level of cytochrome P2D6, resulting in a rapid formation of morphine in them, causing life threatening intoxication, including respiratory depression requiring intubation, can develop over a matter of days. Other patients, 10% lack this enzyme. They lose the analgesic effect of codeine because they are poor metabolizers, but suffers its side effects. Okay, so these are the bad effects of the codeine. Okay, so the poor metabolizer does not suffer its side effect. Okay, because they are poor metabolizers, while the ultra rapid metabolizers can have the problems with the codeine. Okay, because they can convert the morphine easily. Okay, so going to the next question, what is the mechanism of action of paracetamol? So paracetamol is basically both analgesic and antipyretics with unknown mechanism, but mostly act as a selective cyclooxygenase 2 inhibitors which inhibit the synthesis of prostaglandins. Okay, so this is about the action of the paracetamol. Now, how will you manage the paracetamol toxicity? First, we will have to do gastric decontamination by the gastric lavage and activated charcoal. Gastric lavage can be used within minutes of injection, and activated charcoal can be used 30 minutes to 2 hours of injection. Then the N-acetylcysteine, which is the antidote for the paracetamol toxicity, and what it does, that it replenishes the body stores of the antioxidant glutathione. Then the third option in the paracetamol toxicity is liver transplant in those patients who have acute liver failure. A patient present later. Okay, so this is important. How will you assess the patient? How will you assess this patient pain? So by using the pain scoring systems. They are five in number: verbal descriptor, so verbal descriptor scale. So we will have to ask the patient, is your pain 0, which means absent? Is it 1, mild, 2, discomforting, 3, distressing, and 4, excruciating? Okay, so this is the verbal descriptor scale. Then the verbal numerical scale. Verbal numerical rating scale. Which number describe your pain? 0 no pain, 10 worst pain. Then the third scale is visual analog scale. No pain to worse, imaginable. Okay. Then the Wong-Baker faces. These are used for children, so we are basically using the faces, and the expression of the faces will shows us the pain of the children. Okay. Then the functional assessment. Can you move or can you cough? So this will be the functional assessment. So that is that Baker faces pain rating scale. 0, it is the face is smiling, so it means no pain. Hurts little bit, hurts little more, hurts even more, hurts whole a lot, hurts worst. Okay, so these are the pain management scoring system. Then the next station is post-operative fluid management. Okay, so the scenario is 40-year-old lady presented by persistent hypotension and tachycardia post-operative THR and Hartmann procedure. Transfer to the ward 3 p.m. hypotensive and tachycardic 70:30 at 2 a.m. Fluid charts 2 times 250 ml bolus with small improvement initially. Okay, so let's start the question. So the first question is explain why the fluid chart, explain the fluid chart and what is the cause of low urine output. Okay, low urine output. So persistent hypotension and tachycardia with 2 fluid challenges and nothing in between. The patient has reduced intravascular volume, maybe due to inadequate fluid replacement in the post-operative period. Is that adequate? No. Okay, so the fluid management or the fluid replacement is not adequate. So what will be the appropriate management for this situation? Immediate management. Okay, so how we will manage it? So in view of the response to various fluid challenges, we will do more fluid challenges, 250 ml bolus or 10 to 20 ml per kg as fast as possible, and monitor the response. So the other question is, what theoretical physiological rationale for giving fluid challenge rather than speeding the drip up? Okay, so the question is basically why would you give fluid challenge rather than speeding up the drip? So the answer is because the fluid challenge is both diagnostic and therapeutic. Giving fluid slowly doesn't stretch the left ventricle. Okay, according to Starling law. Speeding the drip up doesn't give information regarding the patient's CVS response and may not resuscitate the patient quickly. Okay, so we will give fluid challenge rather than speeding up the drip, because speeding up the drip doesn't give information about the patient's CVS response and may not resuscitate the patient quickly. Formula of fluid challenge, so we will give 250 ml bolus or 10 to 20 ml per kg and monitor the fluid responsiveness. We give 5 ml in cardiac patient, okay, 10 ml in normotensive and 10 ml in hypotensive. The patient is on 2 hours monitoring. Is that adequate? No, because he should be monitored hourly. How to manage this patient after fluid challenge for the remainder of your shift? So we have to regularly review the clinical signs, for example capillary refill time, repeat the fluid challenge if necessary, maintain high index of suspicion for other problems such as occult hemorrhage, leave instruction for nursing staff that they should contact you if they are concerned. Okay, so these are the things to do in the remainder of your shift. Then assuming the patient becomes more hemodynamically unstable and you have give him even more fluid, how to assess the cardiovascular function and patient's response to therapy. Okay, so cardiovascular function and patient response to that can be checked by the first method, which is minimally invasive cardiovascular monitoring, by the two methods: lithium dilution cardiac output monitoring, LIDCO, pulse contour analysis. This is the first step to monitor the cardiovascular response. The, the second is central line, okay, for pulse, and the third is transesophageal Doppler only in sleeping patient. Okay, then who to notify and when? I will notify we will notify my our consultant when no response to multiple fluid challenges. Okay, how blood pressure is calculated? Blood pressure is the product of cardiac output and systemic vascular resistance. The cardiac output is the product of the heart rate and stroke volume. Okay, then how to increase the blood pressure? Okay, okay, so then the next question is how to increase the blood pressure. So we already discussed this. We can give the inotropic support, the fluid to increase cardiac output, and vasopressor agent to increase the systemic vascular resistance. Then the next question is hormonal response to surgery and trauma. What hormone will be secreted to preserve the circulation? Okay, so for increasing the circulation or preserving the circulation, following hormones are secreted. Okay, like the growth hormone, cortisol. Okay, cortisols. Okay, renin, adrenocorticotropic, ACTH hormone, aldosterone, prolactin, antidiuretic hormone, and glucagon. So these hormone increases in level during trauma or surgery to preserve the circulation, while the insulin, okay, the insulin, testosterone, and estrogen decrease, and there is no change in TSH, thyroid stimulating hormone, luteinizing hormone, and follicle stimulating hormone. The next question: where is ADH produced? Okay, and what factor stimulates its secretion? So it is produced in the hypothalamus and then transported, stored, and released from the posterior pituitary. Factors stimulating its secretion are three: reduce circulating volume, increase plasma osmolarity, okay, and angiotensin too. So these are the factors which stimulate the ADH secretion. Okay, and what does ADH do? Okay, so ADH do the increase in water reabsorption. Okay, so it causes the water retention. Okay, water retention. It causes the ADH causes the water retention. Okay, then where in the kidney does ADH act? Okay, so it acts on the collecting duct. Okay, it acts on the collecting ducts. Action of ADH. Okay, so basically it has two functions. One is it increases the peripheral vascular resistance, and other, it increases the reabsorption of solute free water by the collecting duct. Okay, so it increases the water reabsorption and constrict the arterioles to increase the peripheral vascular resistance. By what mechanism? Okay, sorry. By what mechanism does ADH facilitate reuptake of water from the tubular fluid? So it stimulates water reabsorption by insertion of aquaporins, which are proteins or water channels, into the membranes of collecting ducts. These channels transport solute free water through the tubular cells and back into the blood. Why does water crosses the tubular fluid into the medulla? Okay, because of the high osmotic gradient between the tubular fluid and the medullary tissue. Now the next question is, what is the process by which medullary tissue becomes hypertonic? Okay, so the mechanism through which the medullary tissue becomes hypertonic is counter current multiplier mechanism. So what happens in the counter current multiplier, that the descending limb of the loop of Henle is permeable to water. Okay, so one is the descending limb and one is the ascending limb. So the descending limb is permeable to water but impermeable to solute. Thus water moves across the tubular wall into the medullary space, making the filtrate hypertonic. Okay, then the sodium is actively transported out of the thick ascending limb, which is impermeable to water, thus creates an osmotic pressure, drawing water from the descending limb to the into the hyperosmolar medullary space, make the filtrate hypertonic. The counter current flow within the descending and ascending limb thus increases or multiplies the osmotic gradient between tubular fluid and interstitial space. It is the efficient way of concentrating the urine over a relatively short distance along the nephron with minimal energy expenditure. Then the next question, how does aldosterone act to maintain circulatory volume? So basically it stimulates the reuptake of sodium and water by acting on the receptor at the junction between distal convoluted tubule and collecting duct. Okay, then the action of renin. Next question is action of renin angiotensin aldosterone system. So this system involves the angiotensin 2. Okay, so this is how the angiotensin 2 is formed. So first there is stimuli to renin, like the sympathetic stimulation or reduced circulatory volume. The kidney produces the renin, okay, which is the enzyme. It converts angiotensinogen to angiotensin 1, and then angiotensin 1 is converted into angiotensin 2 by angiotensin converting enzyme. Okay, and angiotensin 2 acts on the cardiovascular system. It also stimulates the release of the aldosterone. Okay, and the effect of angiotensin is to increase the blood pressure. So it acts on the cardiovascular system to vasoconstrict the vessels. Consequently it increases the blood pressure. It also secretes the aldosterone, which act on kidney to retain the salt and water. Okay, and subsequently increases the blood pressure. So the basic action of the aldose angiotensin 2 or renin angiotensin system is to increase the blood pressure in response to sympathetic activity. Okay, so the stimuli will be sympathetic activity or reduce intravascular volume. So the angiotensin 2 stimulate the release of aldosterone, and it acts on the cardiovascular system to vasoconstrict the vessels. So this action will increase the blood pressure. So this is the action of the renin angiotensin aldosterone system. Okay, then The next question we will do in the next video.